again, this is all about quality of life and making patients feel better and having them enjoy their time. And so much with gastric cancer, these patients are tough to treat. They have a lot of different things that can happen with them where they need specialized care for some of the symptoms that come along with their disease. So Yelena, can you tell me a little bit about, for instance, how do you approach nutrition in somebody who's had a gastrectomy?
Yeah. Well, it's an adjustment period for the patient. From the day they're diagnosed and they come in to see me, we start this discussion that, you know, look, I practice in New York, and most of these people are hard workers that work, you know, 10-hour days, and they're used to just eating one big meal a day when they come home after work. And really slowly you have to change that practice. I recommend my patients set an alarm clock and eat every 2 to 3 hours, small frequent meals. And really they retrain their biologic clock to get used to increasing their nutritional status, eating, you know, a well-balanced diet. And a lot of patients ask me, look, should I stop eating sugar? Should I never eat red meat again? And they have this perfectionist sort of self-punishing mentality that it's my fault I got the cancer, I'm never eating a single cooking in my life, and then I'll be fine. But really, even though there is preclinical data that sugar may, you know, accelerate growth, in patients, there's no real data to support it. And in fact, what I tell my patients, the cancer will take from your body what it needs, and you really need to support, you know, a healthy lifestyle, balanced meal, and improve your nutritional status, because particularly for post-gastrectomy patients, the data suggests that post-total gastrectomy, folks can lose up to 20% of their body weight. And that's what really limits our ability to get the therapy in adjuvantly, and why we're moving toward getting as much chemotherapy in preoperative setting, and then really optimizing their quality of life and nutritional status in postoperative setting.
And speaking of sugar, so one of the things that happens with our patients is they get what we call, I don't know if they call it the same in the UK, dumping syndrome, right? That you have a heavy sugar load
or carbohydrate
load, and you have a dumping syndrome. I mean, how do you treat dumping? So for the medical oncologist who's having a patient that's having these issues, how do you treat them?
Yeah, so it's also a lot of education with really what you can eat and what you can't eat. And I think I echo what Yelena was saying, that counseling patients with regard to modifying their lifestyle as much as possible is very helpful. I haven't found a medication that actually helps dumping syndrome so much. It's really modifying their diet and modifying their meals to a certain extent. But I also explained that this actually evolves over time. So there may be an episode where or a period of time where they're quite sensitive to carbohydrates and sugars, but over time it becomes less so, and they're able to adjust, and they're able to have some sweets and things like that. I also want to come back to the nutrition aspect. So we recently actually published a paper showing that malnutrition is associated with lower doses of chemotherapy and less survival, which seems obvious, but there wasn't that data before. So we're now running a randomized study to see if nutrition, intensive dietary involvement could actually improve the nutrition and improve the doses that they receive and things like that. So I think it's a very important aspect. A lot of patients do have difficulty with that. And of course, with regard to palliation, there are endoluminal stents that can sometimes be placed for patients who have obstruction in the distal part of the stomach or duodenum that may provide some benefit as well.
Yeah, these are the gastric outlet obstructions that you see, and I don't know if any of you have tried it. I've had a couple patients with really bad dumping syndrome cases, and I've used octreotide, which has helped. But again, it's a lot of testing and diet modification, and certainly with the nutritional aspect, things to think about with your patient with gastric cancer with anemia. Certainly the stomach is used for absorption or easier absorption of certain vitamins. Yelena, you were alluding to some deficiencies that we should probably be watching for.
Absolutely. you know, it's so important to stay on schedule with chemotherapy, and anemia and low counts can really set you back. And a lot of these patients come in anemic in the setting either of a cold bleed, but as you start the treatment, they stay anemic, and that's when it's important to check for iron and B12 deficiencies. Due to poor absorption and malnutrition, these folks are very vulnerable for deficiencies in simple vitamins.
Yeah, so very easy things that are important to check. Ian, you know, ascites, a big issue with patients with gastric cancer. Do you guys use diuretics? Do you find that they're helpful? Do you use catheters, drainage catheters?
Yeah, we do. I think I have to say, you know, we do sometimes give spironolactone to patients, but that usually we don't find it very helpful at all for malignant ascites. So therefore, we will put ascitic drains in, and there are our palliative care service actually have put more long-term indwelling catheter that our healthcare system allow district nursing to go into their home and actually, you know, relieve the drain once every couple of days for someone who's obviously having very problematic ascites. Hopefully, if they're still on treatment and the treatment can be effective and reduce that, but you know, likewise, a lot of people towards their end stage of their journey, that can be a real problem.
Yeah, and you know, like Manish was alluding to earlier, and I think all of you have alluded to, how important it is as a team to treat the gastric cancer patients. And it's not just a doctor team, it's a nutrition team, it's a palliative care team. We've seen so much data that suggests that having a palliative care practitioner along with an oncologist will improve survival. For patients who are going to surgery, physical therapy, all those things are very essential parts of very specialized treatment of these patients. So searching for resources, I think, is a good thing. So let's